Good afternoon. I'm from a small hospital in southern Arizona, and you can see it right here. We're on the border with Mexico. Wherever you hear about the tragedies and that's where I am. And we have about 1 million immigrants crossing our border at this point. We have compassionate entry because anybody who wants health care in the United States can cross the border and get it. The doctors started leaving. About 6 years ago, all the physicians left. We would have no physicians in our community. Now, you got to understand the size of the community. It's about 6,000 square miles. It's the size of Connecticut and Rhode Island put together, so it's huge. And we have one of the highest RUCA codes. I think it's 11 or something like that, rural, and that. So we started putting together clinics. But we did it a little different. We put a medical group in a clinic so the doctors felt independent, but they received a guaranteed income. And that has allowed us to recruit about 10 or 15 physicians in and start to turn the trend around. Our main strategy was primary care. There were no doctors, we're MUA HIPSA. We opened up these 95-210 public rural health clinics. I would ask you to not do away with that program. It's cost reimbursement necessary because of the high unemployment, underinsured, immigration, and just all the bad things that you have in the United States for healthcare we have. And we also did something different. With a grant from an HCAP grant, we put in clinics that have radiology laboratory and a basic diagnostic battery so that you had coordinated one-stop healthcare. In rural areas, people tend not to go back to the doctor, not to go to the laboratory. We do it all in one spot. We are still medically underserved. We are a healthcare professional shortage area. We wanted to expand access through managed care and telemedicine. And because of the high population, where we show that we've got 6,000 square miles, Arizona, we don't have a cardiologist, we don't have a urologist, we do not have any of these specialties or neurologists. So, and we have what really started us going was when the Medicaid program told us we'd have to send a patient to Phoenix to have a lesion on their face looked at. Now that's a 200 or 300 mile drive. How do you, in a high mountain area with the sun in Arizona, do that to somebody? No access to care at all. So we started teledermatology. We won an award for that. The one that we're really proud of is telecardiology. We're not myopic, please. People who use telemedicine are not myopic. This is the first place in the United States to have telecardiology in the ER, the med-surg unit, and in the clinics. We're putting in as we speak today. We put 7 hospitals together. We're called the Southern Arizona Telemedicine Alliance. We looked at the Marshfield Clinic, which was the grandfather of telecardiology, and we're first, as I said, in the nation to do this. We got a $150,000 grant from an insurance company, which, you know, if you can get it from a for-profit, that's a good thing. We'll eventually provide cardiac care and wellness. We'll be able to manage the disease. It's the #1 killer in rural Arizona, and it's lack of access to care, et cetera, that causes this. But what's more important is we've shown significant savings. Over the period of time, and this is a 6-7 month period, we saved the system anywhere from $234,000 to $394,000 from a 15-bed hospital. What we used to do, and let me take the case, 81-year-old gentleman comes in with atrial fibrillation. That's funny beating of the heart from the non-clinicians. We used to put him on a helicopter and ship him. And that was the ethical and efficacious thing to do. But with this now, the cardiologist can visit him in the ER. We had our nurses learn cardiac drips and things like that. And then we put him on an acute unit, and we sent the gentleman home the next day on a Holter monitor. That saved the system $20,000. And so by having this ability in the rural areas to retain patients in a less costly environment, we're able to save the system. But here's the funny thing, and I'll say this. Sometimes I feel like a one-legged man in a butt-kicking contest. UHC gave us the grant, but they won't pay for telemedicine. So we have this disparity between, you know, what's good and what will be paid for. The second program we went into, and we do telepulmonology because COPD is one of the bad ones we have. This is from the Mayo Clinic in Scottsdale. They came up with a telestroke program. And I'm going to go to their slide. And what we do is, instead of what happens with a stroke is that it's not the initial hit. It's the penumbra that develops around it that causes the dysphagia. Case in point, I have his permission to talk about this. Our mayor came in totally disphased along the left side with a history of strokes in his family. He would have been disabled for the rest of his life. We hit him with TPA twice and shipped him. He's a politician again. You can't stop him from talking. He's walking all around and that stuff. But what scares me is they gave me this analysis, and I don't know if you all are teachers in that. Understand, I hate this because it says this thing is efficacious to do. If it wasn't, would you not do it? So you have the actual clinical studies on this to go ahead. By the way, we use home health, and our doctors do visit the patients through the home health, and we don't charge for it. It's just what is best for the patient is what we do. We have a fully integrated system. What happened to us is happening in most healthcare systems now. All our doctors are employed by the hospital. They operate in the clinics, and so we're totally integrated. We couldn't survive without it. Recommendations. Please maintain cost reimbursement for medically underserved populations in rural health clinics. When you start to see the Medicare cuts, at least 50% of the hospitals are negative. If the cuts go through that the state of Arizona is planning and the state and the federal cuts, we will close 50% of the hospitals on the border with Mexico. It's as easy as that. Expand the definition of what's primary care. Expand it to include cardiology so that we can have the cardiologist bill through our clinics, and it's a flat rate no matter what it is, and we'll be able to do that. We do it for OB-GYNs. They can work in these RHC clinics. By the way, also, we had the case of our nurse practitioners. They're really practitioners. They're not extenders. So the state of Arizona has a law that says they don't need to be supervised, but the feds came in and cited me for not supervising them acutely. So we've got a disparity between the two laws. There's another thing coming up. We're all going after the definition of medically underserved and healthcare professional area. The problem with that is that if the law that was under Bush's administration had been passed, we would have lost 17 of our MUA, HIPSA, and 17 clinics, which were the only access to healthcare in these areas, would have been closed. Recognize telemedicine as a compensated service. Medicare and Medicaid will pay for telemedicine in MUA and HIPSA areas, but there's no reason that this integrated model couldn't work in an urban area. You bring people access to care, you can save money by having this coordinated care where specialists are not available. Now in Arizona, Arizona was settled by where the gold and the copper was. So we have this great spread out area. Everybody likes Tucson and Phoenix, but out in the other areas, it's not that way. So it's a way to handle physician maldistribution and shortages. Payment parity level. Don't let United Healthcare, Blue Cross, and all the other ones shove it onto Medicare and Medicaid. There should be a national mandate to cover telemedicine and as if it was the same service rendered by the bedside. And it is in my case. There is no question about that. Everything done, total workups and that in the facility. Mandate telemedicine as a covered service and insurance exchanges. You have these new insurance exchanges coming out, and what they are doing is the one that the state of Arizona is proposing exempts them from mandates. So that means that if we have a telemedicine mandate, which the state is I'm working on with a group of other hospitals, it wouldn't have to be an insurance exchange, and therefore you've got a half system. So that's what I recommend. I work in a very rural area. I love it. I love Arizona. I wish our governor would be quiet. I'm having trouble recruiting doctors now, but we're doing the best we can. I think we're innovative, but we need the help of the federal government to recognize it as an arm of healthcare as much as a doctor or anything else. Thank you.